Hello and welcome to week 4 of PUBH 610. Today we will review health services financing in the U.S. healthcare system and build on our discussion last week of the evolving healthcare system in the United States. The learning objectives for this week are to understand the role of healthcare financing and its impact, to make sure you are familiar with the general terms used in health insurance and the concept behind insurance, to review the features of the public insurance programs that we didn't discuss last week, like the VA and CHIP, and review different methods of reimbursement and trends in reimbursement, such as the move toward a value-based payment system, and the effects of the ACA on financing and insurance. And lastly, we will discuss current issues in healthcare financing and directions. As we discussed last week, the U.S. is a complex multi-payer healthcare system with a mix of private health insurance companies and government-funded public programs for certain populations. However, this week we will discuss in greater detail how these payers are funded, how they're not mutually exclusive, and how many people are dually eligible for both Medicaid and Medicare or other combinations of coverage. As we discussed last week, we know that insurance in the United States is, for better or worse, tied to employment and heavily subsidized by the employer, and that this makes the purchasing of private individual coverage very expensive and rare in the United States. And this is despite tax and financial incentives, the individual mandate, and creating a more transparent and user-friendly health insurance exchange. Here in this graph, we can see the proportion of public and private national health expenditures over time. And we can see that the proportion of public expenditures has increased since the Affordable Care Act was passed in 2010, and Medicaid eligibility, for instance, was expanded. Despite that expansion, the private sector still dominates in healthcare expenditures. When we talk about health services financing, what we're talking about is paying for health insurance premiums. In the U.S., doctors rely on insurance companies to get paid for the services they provide. As we discussed last week, financing to a large degree determines who has access to health care. But charity care is available for the uninsured in case of an emergency. Because health insurance decreases the cost to patients, it increases demand for healthcare services. This is known as moral hazard. For example, I have health insurance, so I made an appointment at the dermatologist. I don't have any immediate concerns, but I'm electing to go because health insurance will pay for it. That is moral hazard. Continuing with the dermatology example, financing influences supply-side factors as well. For example, if all insurance covered dermatology appointments at 100%, there would be an increase in the number of people wanting to see dermatologists, and therefore more people studying to become dermatologists, or perhaps more dermatology offices opening up in a certain neighborhood. In 1992, Medicare began using a resource-based relative value scale to reimburse physicians. The goal of this was to encourage more doctors to go into primary care by increasing the reimbursement for primary care services. However, despite this effort, more doctors continued to become specialists rather than general practitioners in the United States. Here is a conceptual model of cost control in the United States. In this model, insurance is the main factor that determines demand for medical services. Reducing financing for insurance would lead to reduced demand for physician services, which ultimately would control total healthcare expenditures. Conversely, if we expand health insurance to the uninsured and we do not limit the supply of medical services, this will lead to increased healthcare expenditures. So in this model, you'll see that insurance with payment and price is equal to P. This influences the supply. And insurance and supply of services determine access and service utilization, which is the quantity of services consumed, which equals Q. And P times Q is equal to healthcare expenditures in the United States. Insurance is a mechanism for protection against risk. Risk refers to the possibility of a financial loss from an event which has a relatively small probability of occurring. Risk for a large population can be predicted with reasonable accuracy, but it is unpredictable for the individual who is insured. The idea of insurance is that risk transfers from the individual to the group, and members of a shared group share losses. Private health insurance is also called voluntary health insurance, and as we discussed last week, is mostly employment-based in the United States. Workers do not have to buy it, but the ACA mandated that businesses with at least 50 full-time workers must offer insurance to their employees. Most of us have heard of these terms, or seen them on our health insurance documentation. However, it's important you understand what each of these terms means. Premiums are the amount charged by the insurer to insure against risks. Experience rating is a way to determine one's premium. Under experience rating, premiums are based on a group's own medical claims experience. People who work in a more hazardous job will have higher premiums because they are more likely to get sick, while community rating spreads the risk among members of a larger population or community, and premiums are based on the utilization of the entire population covered by the same type of insurance. Please see page 223 in your textbook to review these terms and make sure you have a good understanding of each of them. The Affordable Care Act is a large and complex piece of legislation with many different aspects. However, here are the 6 main provisions. As we discussed last week, the ACA is not perfect, and deductibles are often unaffordable, and some large insurers left the Affordable Care Act exchanges. However, overall, many of the provisions, such as making it illegal to refuse coverage for pre-existing conditions, and allowing young adults to stay on their parents' plans till the age of 26, are very popular. Also, some things didn't last, as we discussed. Trump overturned number 6, and there is no longer an individual mandate or a penalty for not having personal health insurance in the United States. Last week we discussed Medicaid and Medicare, and this week we will discuss some of the other public health insurance programs in the U.S. like CHIP and the VA. But before I move on, I do want to highlight that approximately 9 million people in the United States are dually eligible for public health insurance. That is, that they are low income and elderly, or they're disabled young adults who are entitled to Medicare. Dual eligible can be partly dual eligible, where Medicaid pays for some of the costs, such as Medicare premiums or co-payments, or it can be fully eligible. Many elderly persons become dually eligible when they get sick and require long-term care, and they need Medicaid rather than Medicare to pay for their long-term care services. But in order to become Medicaid eligible, they must spend down their savings and become poor enough to become Medicaid eligible first. I also want to highlight that another challenge with Medicaid, which we didn't discuss last week, is that the reimbursement of Medicaid providers is less than what is paid by Medicare and private insurance. This leads to poorer quality of care for poorer patients with Medicaid, and limited access, as some providers do not want to see patients with Medicaid, since they do not get paid as much as other types of patients. The ACA attempted to address this disparity, but it was not successful. Another public health insurance program is called CHIP, the Children's Health Insurance Program, which was created in 1997 to make sure that uninsured children whose families made more money than the Medicaid threshold would be able to get health insurance. Under CHIP, children can receive coverage up to age 19. Federal funding is distributed to states in block grants. There is no federal income threshold, but many states will cover children and families with incomes up to 200% of the federal poverty level. That means that in 2019, individuals can earn up to $24,980 in states with the 200% threshold and still be eligible for CHIP. The VA, the Veterans Health Administration, is the largest integrated health system in the United States, with more than 1,700 sites of care and serving more than 8.7 million veterans. And it controls costs through the use of global budgets, which means that the budget is determined and approved in advance for the entire system for the entire time period. There are 23 geographically distributed networks, and each is responsible for coordinating the activities of the hospitals, outpatient clinics, etc. Despite many successes, the VA suffered from some highly publicized reports of lack of access to care and preventable deaths that occurred while vets were waiting for care in 2014. And this led to Congress passing the Veterans Access, Choice, and Accountability Act, which allows veterans who experience long wait times or live 40 or more miles from a VA facility to see another community-based provider. Fee-for-service is the oldest method of reimbursement and is still used, but not as frequently as before. Under fee-for-service, the more services you get, the more you have to pay. This leads to overutilization and doctors running unnecessary tests and procedures. Fee-for-service pays for each itemized service, but a bundled fee is a set price for a package of services, such as an eye exam and eyeglasses for one flat fee. Bundled fees reduce the incentive for unnecessary services. Medicare pioneered diagnostic-related groups, which pays one sum for a given episode from start to finish at the hospital, and was very successful at controlling costs through this payment function. As I've said before, Medicare is a trendsetter and continues to set innovative and new strategies and is moving us toward a value-based reimbursement system to improve quality and reduce costs. Under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015, Medicare implemented a quality payment program that will start paying doctors based on the quality of their care and performance for their patients. Essentially, if doctors see a patient and they do not get better, they will not get paid as much as the doctor who sees a patient and the patient is no longer sick. As I just mentioned, we are increasingly moving toward a healthcare system that is focused on value and making healthcare more affordable for more people. Unfortunately, under the ACA, we also experienced adverse selection, which occurs when high-risk individuals who use more health services sign up for health insurance in greater numbers than healthy people. When this happens, premiums must be raised for everyone, which makes insurance less affordable to those in good health. The individual mandate attempted to limit adverse selection by forcing young, healthy people to purchase insurance, but that is no longer in effect. Cost shifting is when providers push costs onto private insurance to cover shortfalls in public programs such as Medicare or Medicaid payments. The expansion of coverage under the ACA will in part be paid for by reducing payments to hospitals and providers, and in response, hospitals and doctors' practices have consolidated, and in some places this limits access to care. As with anything, you need to follow the money. How we finance healthcare in the U.S. determines who pays for and who receives services and what types of services they receive. It's important to remember that financing impacts both the supply and demand side of the healthcare equation, and we must think about how changing reimbursement rates will impact who practices what type of medicine, what types of medical technology we use, and how hospital mergers will affect people's health and access to healthcare and quality of healthcare in different parts of our country. That's it for this week. Please check Blackboard for any additional materials.